Assalamu alaikum. My name is Dr. Shokat. I'm consultant nephrologist working in this hospital, Karachi. And today we will discuss about the different scenarios which we encounter day to day life in emergency in the ward and ICU. So far we've discussed four different aspects of the blood gases. Started with anion gap, then buffer, then we discuss about the oxygenation, the tissues, and delta anion gap. Now the scenarios will be discussed. So before I go to a first scenario, so I will tell you we usually see the compensation of PCO2 through the winter formula, or sometime for the sake of easiness, I just use the this formula. One drop of bicarbonate causes how much drop of the PCO2 is 1.2 times. So I will teach in examples when we discuss the scenarios. So let's have a look in the first scenario. 22-year female, type 1 diabetic है और she came to the emergency department with one history of the nausea, vomiting, polyuria, polydipsia, and vague abdominal pain. So each scenario will be discussed in such a way that this suggests towards the certain diagnosis. The trainee who work in the ward and emergencies, so they come across such scenario and make the opinion from that time. So on examination, the deep sighing, breathing, orthostatic hypotension, and dry mucous membrane, and the lab parameters show the glucose 1/720 milligram per deciliter, and ketone or TRAS with the creatinine 2.6, and urine analysis says the pH 5, glucose positive. So this scenario with this examination and the laboratory findings is suggestive of the typical the presentation of the DKA, diabetic ketoacidosis. So we find acidic pH 7.27 with the BICAP 10, PCO2 23. So let's have a look. Is it valid with the internal consistency or not? Then we will see the other aspects. So when we try to see the internal consistency, we use this formula. The hydrogen ion concentration is equal to 24, which is standard, and PCO2 of patient divided by BICA. When we put these values, then we find the hydrogen ion 55.2, and this correspond over here almost 7.3 pH, and this is very much near to 7.27. So this is consistent internally. So second step will go with anion with the calculation of anion gap by the serum electrolytes. So we know with sodium minus chloride plus bicarbonate max the anion gap, and which comes as 28, which is high. And the compensation, we can use the winter formula, or just I told you, okay, 1.2 times drop of the PCO2 for each one drop of bicarbonate. Here, the bicarbonate is 10, so 14th drop of bicarbonate max, almost 17, near to 17 drop of PCO2 from standard 40, cut off 40. So the 17 drop of cut off 40 makes almost how much? 23. So this is adequate compensation. So we can say, we can conclude this is the high anion gap metabolic acidosis typical scenario. So let's move towards another scenario. 60-year man presents nausea, vomiting, poor intake, 2 days history, and the patient reports 3 days history of the binge drinking prior to symptoms. So here this scenario explains to us something. The clue is given over here, the binge drinking. So certainly we are encountering someone with the alcoholic metabolism, alcoholic acidosis, uh, and here the electrolytes, sodium, potassium, you can see over here, and with the creatinine of 1.3 and glucose 75, the serum albumin 1, and this is the blood gases with mild acidosis. And when we read the blood gases, we see the after pH, we see the PCO2 which is dropped. Then we can say straight away again, this is not respiratory acidosis. As in respiratory acidosis, the PCO2 should be more than 40. But here we encountered less than 40. So at least we can see over here by the second step, okay, this is not something related to respiratory acidosis, this is metabolic acidosis, and the bar is 16. Then see, we can see the compensation, the drop of the bicarb, how much drop it is from the 24 standard is 8 drop. So 8, how much PCO2 should be dropped? Almost 1.2 times for one bicarb. We can say around 10 to 11 should be dropped from the standard 40 PCO2 and patients 29, so almost adequately dropped, adequately compensation. So this just helps us to just rule out the second disorder. We know when it is dropped more than it is second suggest of the second disorder respiratory alkalosis. When it's dropped not that much, means retained, then the second disorder is respiratory acidosis. So here the anion gap is normal, but the caveat is that albumin is one. So you use prior knowledge. We need to calculate the anion gap with the serum albumin. Otherwise, we may be misguided. So for the corrected for the corrected anion gap, we need to use this formula where we put the current anion gap plus 2.5 into bracket 4 minus patient's albumin. So here this will make almost 19.5. This is corrected anion gap. If we do not encounter albumin, then we may mistakenly tell, okay, this is the toil and toil is normal, but this is high anion gap metabolic acidosis. So let's move the third scenario, 44-old, moderately dehydrated, and to the history of the acute severe diarrhea, uh, and the electrolytes these, where you can calculate the anion gap, and the pH mildly acidic, and after the pH we read the PCO2 again. This cannot be respiratory acidosis, as at least we can say this cannot be predominantly as respiratory acidosis, as the PCO2 is lesser than 40. Now again the same level of the bicarbonate as previous scenario, so something around 30 PCO2. This is 33. It's a fine, it's not that much deranged. The hydrogen ion is 49.5. It's just for the internal consistency. If we see the 49.5, then we know it corresponds to 7.3, and the pH is 7.31. So it's internally consistent as well. Anion gap is 10, and the expected PCO2 we told this is 31. So what is the diagnosis? The normal anion gap metabolic acidosis and adequately compensation. We do not need to write the adequate compensation. We need just to calculate it, but don't need to write it down over here. I just wrote, but we don't need to. So this is a normal anion gap metabolic acidosis. Now another scenario, 44-year-old moderately dehydrated man was admitted with 2 days history of breathlessness. Now this time the history of breathlessness, and previous scenario we encountered the diarrhea. And the labs are the blood gases, acidic pH, PCO2 again less than 40. So this is metabolic acidosis. So let's see the compensation in order to rule out the second disorder. At the level of 14 bicarbonate means the deficit or the drop of bicarbonate is 10, and we know at 10 the PCO2 should be around 27 plus minus 2. The 27 plus minus 2 is 20. The patient's PCO2 is 20, is more dropped. So we can say the simultaneously respiratory alkalosis is there along with the metabolic acidosis. And what about the anion gap? We can say the anion gap is 22. So high anion gap metabolic acidosis along with respiratory alkalosis. So this is dual disorder. So see, the compensation help us to in order to rule out the associated disorder. So this is another scenario: 60-year-old woman with lobar pneumonia, thyroid diuretic for 9 months, following previous admission with congestive heart failure. So the scenario guide us to a certain disorder, expected disorder in the blood gas, like lobar pneumonia patient may have a hyperventilation. So we may encounter the respiratory alkalosis in such patient. Sometimes these patients get tired later on and retain the PCO2, so they may be found with respiratory acidosis too. So we need to be vigilant. Okay, we might find the respiratory alkalosis as well as in some patient respiratory acidosis. And someone on the thyroid diuretic, yes, we know the side effects. It causes contraction alkalosis. So both of the element of alkalosis can be expected in such patient. One is the respiratory alkalosis, one the metabolic component. So see, uh, in the blood gases, so this alkalotic pH 7.64 with the PCO2 32. We know in alkalotic uh, PCO2 is should be lesser if it is the respiratory alkalosis. So it is towards the respiratory alkalosis. So if this would have been single disorder, then the compensatory bicarb should be lesser than the 24, but more than 24. So simultaneously, metabolic component of alkalosis is here along with the respiratory alkalosis. So we are dealing with the patient of metabolic alkalosis plus respiratory alkalosis. Another scenario: 28-year female Sjogren syndrome, to restrict body ache and otherwise fine, and physical examination again reveal nothing significant. So in Sjogren syndrome and in the nephrology context, what we can encounter some certainly some tubulopathy. Here we see the electrolytes 136 sodium, 3.2 potassium, and chloride bicarb is this, and urine pH is 6, and urine electrolytes is certainly we are dealing with renal tubular acidosis. Anion gap is normal, which is suggestive of renal tubular acidosis. So we can get the clue from the scenario, and then we can see the low bicarbonate. Uh, this is usually encountered with normal renal function, but renal function are not given over here. But usually we find the normal renal function and the low bicarbonates. So the low bicarbonate with the low potassium is suggestive of the renal tuberculosis, and we know we find the anion serum anion gap is normal, and the urine anion gap is positive. But how do we calculate urine anion gap? We know sodium plus potassium minus chloride is the formula, and there's no role of bicarbonates, as bicarbonates usually very negligible amount in the urine. So it is normally positive urine gap, but it's more pronounced in the cases of the renal tubular acidosis. So urine gap 26, type 1 RTA, and this is a very well-known association of the Sjogren syndrome. So we discuss another scenario, then we will stop over there. So 70-year-old man, history of congestive heart failure, and increased short of breath with low leg swelling. The blood gases pH 7.24, PCO2 60. Here you can see the acidic pH with the PCO2 more than 40. So we are dealing with predominantly respiratory acidosis in such cases. And if this single disorder, the compensatory rise of the bicarbonate above the 24, there should be expected above the 24 and 27 with hypoxia as well. And what is the diagnosis? This is acute respiratory acidosis, likely secondary to pulmonary edema. So here I stop, and I have saved some of the very important scenarios for the next video, which are dealing with more than two disorder and delta delta gap. I have just got some practice with you people. about the simple scenario and very commonly encountered scenarios in our day-to-day practice. So hopefully this may have cleared some of the concept of many people. Thank you very much and take care and subscribe the channel. Thank you very much.